PHFI started recognizing that primary care physicians need a lot of training across the country if the challenges of NCDs has to be met. So we designed courses for them, which are convenient for working professionals to take and to enhance their knowledge and skills in dealing with these with much greater confidence and competence.
We currently have trained 20,000 primary care physicians so far in the last.
It's very difficult for the doctors outstation to spare their money, but I try to prove its worth. As we are just seeing in the videos, is about PHFI, Public Health Foundation of India. This is an NGO. Now, when these Sun people approached me about this program, initially I thought it is just like any of the other programs that we come across. Say we are conducting this trial, examining 10 patients, major BP of 15 patients, and that sort of thing. And I was very reluctant to sort of take this further. Then got a call that there is a regional meet in Delhi. This meet was somewhere in last week of May. With great reluctance, I attended that meet. When I actually went there, it was a totally different surprise. Surprise in the sense that the people I met there were truly extraordinary and authorities in their own sense. You can say who's and who of India's cardiology was there. All top academic cardiologists in the country were there. And they were thorough academicians. And they were very serious about this program. The sort of interaction that we had. In fact, that program is what we are going to see in the next few hours. Is this program, that the program which we designed there. That means the national faculty, there were a few national faculty, they had basically formed the core of the program 2-3 months before. They had decided upon the structure of the program, formulated some slides. Then when we went there, we were 50 odd regional faculty who went there. Then each slide there, we discussed what slide to be included, what not to be included, what needs to be added in the slide, what needs to be deleted, and every slide was discussed. And this is a very structured program in the sense that this is a protocolized all over the country. Means I am not allowed to change this program. I can't put my slide in, nor can I delete the slide. Everything has material is come from there. And this material is discussed literally thread and there in the national and regional faculty meet. At that meet, there were representatives from American College of Cardiology who gave a lecture, gave their input, contributed some slides. Then there was a representative from Royal College of Physicians, London. She came, she also gave her slides. And so this is a very serious sort of program. In fact, there was so much brainstorming during that program that we ourselves felt that we learned a lot, many things in that program. So as we'll see that although I am teaching you or I am giving you this doesn't mean that you are learning and I am teaching. No, we all are learning together. Because I have also learned many new things from this program. Just to say that after the end of the program, when we were just going to the airport, one of the senior faculties, he told me, स्वतः लागवटी नहीं लोकांकडे बघू. That was the feeling. They were so thoroughly academic people there and doing such a good work that we felt ashamed that we have to do something academically, contribute more academically. Now, just you have seen the persons behind it, the main man, Dr. Dilkar Prabhakar, who was Vice President of PHFI. one of the national faculty, he told me that you will see this man is a very low profile man, but this man has maximum publications in India. He has publications in any topmost medical journal, Lancet, New England Journal, take any journal, he has maximum publications, and he is the always a common invite to any international reputable conference. So he is such a respected man all over the world. So these are the persons who are thorough academicians. They have designed the program, and this is a structured program. And what has been discussed, we are just going to pass on to the knowledge, and we just, this is not a final thing. See, we are going to evolve. Maybe certain things, if we don't like, if we need more emphasis on this feedback, we'll give back to them, and we'll formulate the next course accordingly. So this is not the end of it. Now just this is a serious certificate course. Perhaps you must have known that there are 12 modules. Once every Sunday, every month, once a month, every Sunday, one Sunday a month, we are going to do this for 12 Sundays, one full year. Then there will be a exit exam at the end of the course, and if you score more than 50% marks, you will be getting a certificate which will be co-signed by Royal College of Physicians and American College of Cardiology besides the PhD file. So this is, I don't know how much of this is going to be useful in practice, but one thing I can guarantee you, though it may not be useful in your practice, the way you treat your patients or the way you approach the subject, that is going to definitely change after you go through this program. It's the basic understanding of the subject, what to look for, and the basic concepts of whether the diagnosis or the treatment. Because see, you, me, many of us, we have passed our academic maybe 20-25 years ago. We are getting out of touch now, and whatever the knowledge we get is tidbits we learn from the internet or through some trials presented by medical representatives, and we really don't have time to go back to and learn everything in detail. So this program might fill in that gap and might help us. Certain things we want to know, but we don't get time, we don't get adequate sort of material, and I think that program is to serve. Especially one thing like biostatistics, you will see this. There are certain things we want to know, we don't understand when we read a paper, but this should serve it, I think. Now, just before I start the program, just to tell you, there is a pre-test. So you will be given a questionnaire, sort of some 10 exam questions which you have to mark, and then you start the program. Please distribute the here, Mangesh today.
Maharashtra has 6 centers: Mumbai, Thane, Pune, Aurangabad, Solapur and Nagpur. These are the centers in Maharashtra. All are direct from Jammu Kashmir, I think from Punjab to Kerala, all, and from West Bengal to Rajasthan. All the centers, all the states have been covered. So these are the different modules, 12 modules in this program. that you will see. Today's module is about introduction to cardiovascular disease and evaluation of coronary disease. Now the course objective I told you, as you have seen in that video, is that it is to enhance skills and you have to upgrade ourselves. And both it's for both you and me. So these are the learning objectives. I'll just keep this slide. Now before we go to the program proper, epidemiology. This was, I think, optional topic for many of us when we did our MBBS, biostat, just we got through it. But it's very important thing as we know today. Whenever we are presented any trial paper or some representative from company tells us this is so much risk reduction, this is the odds ratio. We actually don't take and we take it at their face value. But we should know which point needs to be mentioned in detail, which carries real relevance, and what to see in a particular trial. That we have to know. Then only we can know whether a particular treatment is beneficial or not. And for that, some basics. I am not going to go details of epidemiology. It's not part of this thing, but we should know certain terms in epidemiology that we regularly come across, and we should know whether a particular study is really important or not. As you will see, the basic epidemiology means, AP means upon, DB means people, and study of people, basically study of people. Now when you go, the epidemiology is basically what? For prevention of cardiovascular disease. Now this is the cardiology continuum what you see. If you see a timeline of the cardiovascular disease, first you have a pristine body, a pure body without any risk factor exposure. Then you have risk factors. Then you, because of the risk factors, you develop cardiovascular disease, heart disease, stroke. Then you have recurrent. So first infarct, second infarct, complication of infarct, or you have end-stage heart disease or death. Now this is the continuum of a cardiovascular disease. Now to prevent this, you have different levels. If you act before the development of risk factors, means if you are able to prevent diabetes, prevent hypertension, then that becomes a primordial intervention, a primordial prevention. So prevention of development of risk factors, that's a primordial prevention. After the risk factor, if you prevent the disease from occurring because of those risk factors, that's a primary prevention. And once you already have a disease and when you are going to prevent its recurrence, second event, then that is secondary prevention. So now this is epidemiology we just gone through. Now this is very important. This is a very good slide. It tells you the difference between incidence and prevalence. Now this is a water tank. This water tank, you have a continuous inflow and an outflow. There is some water level which is being maintained.
So the water level which is being maintained is prevalence. That is number of cases at a particular moment, that is prevalence. The water which is incoming, new cases, that is incidence. So new cases is incidence. Over a year, suppose new cases occurrence in 2018, that is incidence in 2018. So that's an incidence. Prevalence means at a particular time of August 2018. What is the prevalence of ischemic heart disease in Shola? So that's the number of cases at a particular time, and this is incidence. Now what is relative risk? Now suppose there are 10 persons, out of which 6 are exposed to smoking, 4 are not. Out of, suppose I say if there are 10 people who are exposed to smoking, 10 people who are not exposed to smoking. Out of 10, it was suppose if 4 develop ischemic heart disease, those who are exposed to smoking, and those who are not exposed to smoking, 2 out of 10 they develop myocardial infarction of ischemic heart disease. Then the relative risk, now this is 4 upon 10, it's 4 out of 10 in exposed group and 2 out of 10 is non-exposed group. The ratio between these two, 4 upon 10 upon 2 is 10. This is a relative risk. Means those who develop, the ratio of those who develop from exposed to, so here smoking is a risk factor. So we want to see what is the relative risk of smoking on development of ischemic heart disease. So 4 upon 10 upon 2 upon 10. So you can say 50% upon 20%. So 2.5. So 2.5 is the relative risk of this smoking confers on development of ischemic heart disease. So those who develop in the risk factor, the ratio of that to those who develop who are not exposed to risk factor. In other ways, odds ratio is same. Now what is odds? Odds means suppose out of now dice, you see dice, there are 6 probabilities. Now if you want to strike 6 in when you toss the dice, then the odds are 1 in 6. So 1 is a chance, the probability is 1 in 6 that you are going to strike a 6. But the odds are 1 in 5. You get the difference between probability and odds. The probability is 1 in 6 that you are going to strike 6 in that dice. But the odds are 1 in 5. Odds is the ratio of the occurrence of event to non-occurrence of event. So 1 in 5, 6 minus 1. So 1 in 5 are the odds and probability is 1 in 6. That is the difference between odds and probability. And when we take the ratio of odds, so those who, suppose now smoking, those who develop from smoking, those smokers who develop infarction and non-smokers who develop infarction. When you divide this, that's the odds ratio. Okay, so odds and probability. The probability is always between 0 to 1. Remember, 0 to 1 is always probability. While odds can be any positive number. That means smokers are more than twice, they have odds of more than twice, more than thrice, more than 4 times. But probability is always between 0 to 1. That's the difference between probability and odds. So odds of developing infarction because of smoking is 2.5 times, you can see. Similarly, relative risk and odds ratio is same. It is 2.5 times. But probability is slightly different. Now, what is attributable risk? Suppose you have 100 patients of myocardial infarction, out of which 25 infarctions are because of smoking. In 25 cases of myocardial infarction, you have history of smoking. Okay, so out of 100 cases of myocardial infarction, 25 had history of smoking. So the attributable risk is 25%. What do you mean by that? If you stop smoking, these 25 infarctions will be prevented. Okay, so the attributable risk of smoking is 25%. So how much of total infarctions are attributable to smoking is 25%. So that's the attributable risk. You're getting my point? So attributable risk is how much of a total events a particular risk factor contributes. Out of 100, 25 are because of smoking, 25 are because of diabetes, 15 are because of hypertension, and 50 we don't know. So the attributable risk to a particular risk factor. So if that risk factor is controlled, then that much infarction or that much event can be prevented. So what is the attributable risk? Because these are the 3 different terms that one has to be familiar with. Now this is the same thing which I told you, what is odds and what is relative risk. Now this is very important and I find this is the most important, absolute risk reduction. So whenever you read a trial, whenever you read a paper, go for absolute risk reduction. This is the most concrete hard criteria. But relative risk is a soft criteria. Absolute risk reduction is a hard criteria. What is absolute reduction? Suppose 100 patients are given aspirin after myocardial infarction. The second, those who are 100 patients are given aspirin out of which, suppose we are able to prevent a reinfarction because of aspirin in 30% of patients. Means one is given placebo, in then the reinfarction is 50. and second is given aspirin, and then the infarction is 30. Okay, so you have 50 in placebo group infarctions, 30 in aspirin group. So the absolute risk is 20 minus, it is not a ratio. Remember, it is minus 50 minus 30 is 20. So it is a subtraction. This is more important. Relative risk is a ratio. This is absolute risk, is a absolute value. And if you do percentage of it, suppose out of 100, if there is 20% risk, absolute risk reduction, this out of 100%, if 50% of placebo they get mild infarction and 30% of aspirin get, you have 20% absolute risk reduction. Why absolute risk reduction is important? 1 upon absolute risk ratio gives you what is called as an NNT. Now, I am coming to what is NNT. This is attributable risk I told you, relative risk I told you. Now, this is very important. Whenever you read a trial, see what is NNT. Forget about what I have told. Absolute rates, relative risk, odds ratio, all confusing terms. When you read, you don't calculate them. You just see what is NNT. NNT is number needed to treat. How do you arrive at number needed to treat? Is 1 upon absolute risk reduction. Okay? So it goes right further in detail. Now suppose this is a particular 30-day mortality rate. In placebo, it was 40. In treatment, it is 30. If it is about 100, it is a 10% risk reduction. Then 1 upon absolute risk reduction, 1 upon 0.10 is 10. Okay? Got this? So number needed to treat. This is very important. So I told you, forget everything what I told. Just remember what is NNT. Any trial if it mentions NNT, that is important. Means if you treat 10 patients, you save 1 life. This is NNT. So this is most important. So if NNT is less, then that treatment is very effective. Means if you have to just treat 10 patients and you are going to save 1 life. Compare this if you have to treat 1,000 patients. Now say something like chemotherapy for a particular disease. Very expensive. Now if you have to treat 1,000 patients with so much of costly treatment to save 1 life, it may not be worth it. Remember, but now see aspirin. If just treating aspirin NNT is somewhere around 30. So if you treat 30 patients, if you save 1 life, then that's a very good drug. So NNT is the most important thing when you read a particular thing. Similarly, NNH, number needed to harm. Okay. So if there is a harmful particular thing, maybe a harmful risk factor like smoking. How many people smoke and how much of them get harm? So it is NNH similar. So number needed to treat and number needed to harm. These are very important. So for common diseases, if NNT is less than 100, then that's a good treatment. It's worth trying that treatment. NNT. So if you are not able to understand anything, I have told you before, just only remember NNT. Every trial you see what is NNT, number needed to treat, number needed to harm. Now this is another Forest plot which you commonly encounter. Which you commonly encounter. Now just because, and this is very important, when you look at it, and this Forest plot is always there, and always look only a thing. The summary of any trial is this. Now do you have a central line? This is 0. Usually they say favor control, favor treatment. These are what? Favor a particular drug, favor a particular other drug. So this all is comparison on this Forest plot. Now anything on this side is harmful, anything on this side is favor. Always. Okay. If you are anything on this side is harmful, anything on this side is favor. So any of your treatment results, intervention should be on this side if it is useful. Anything on this side is always harmful. Now these are the various, what are plotted and all the trials which look at the same endpoint. Suppose how much peptopalin is useful in myocardial infarction. If there are some 10 trials, then they all are plotted here with their mean in the center and standard deviation on either side. Okay, so they are plotted here. the size of the box or diameter of the box represents size of the sample population. If particular trial has 1,000, it will show a particular size. If it has 100 patients, the size will be smaller of this box. Since the size of this box is smaller. As you know, larger the size, more weightage it will carry. Naturally, if the more patients are studied, naturally the weightage will be more. So you have to look at which has the more patients studied. That is going to carry more weightage. And the last line here always is the summary. Summary of all these trials. So you look at only this thing. Whether this is on this side or this side. Because some trials may be favorable, some trials may not be favorable. So you look at this. If it's going on this side, that treatment is not useful. If it is in the center, it is neither useful nor harmful. Okay, so you always look at forest plot, you always look at NNT. These things you have to look for. And that's all that. Nothing else you have to look at the particular trial. Then you will know whether the particular treatment is useful or not useful. Now this is an example of LDL cholesterol reduction in cardiovascular disease. These are all the trials. They looked at fatal MI, CHD, major coronary event. These are the all trials. And consistently you will see that all the trials have shown that treatment is better. LDL cholesterol reduction. Different trials have different numbers. And all the trials have shown, and one trial has shown perhaps LDL reduction might increase the incidence of hemorrhagic stroke. Okay, so only one trial, this has shown that hemorrhagic stroke might be increased. This is now, if you go into depth, this was probably now they have not given a p-value here. This is not significant, but that's a point of concern that you have to remember. That LDL reduction is definitely useful, but one point of concern is it might increase incidence of hemorrhagic stroke according to this you have to remember. Otherwise, so now this is a common I told you the last line is a summary of all these any vascular event. Now these are the total number of patients. It is definitely useful on this side. Treatment better. So LDL reduction is definitely better. So this is just you see this forest diagram and you see NN. That's all, and you get the gist of what that trial has to say. Now coming to actual statistics. Now these are what is a cardiovascular disease. You will see all this. Except cerebrovascular disease, everything deals with the heart. Arrhythmias, coronary artery disease, rheumatic, congenital, EVT, peripheral artery disease, myocarditis. All this is cardiovascular disease. And because it is because it is a vascular disease, strokes are also included as a vascular event, and they form the part of this course, treatment of stroke. This comes in the part of treatment of this. So I am a cardiologist. I have to take you about stroke. Okay. Now this is the classification of cerebrovascular disease and coronary heart disease. These are the things which we know. Now what is the global? Now, this, if you see this statistics, they are really frightening. You will see this is the total prevalent cases globally, and the aim of is to reduction at least 25% relative risk reduction by 2020 because of the such programs and awareness. Now these are the key facts. You pay very careful attention because these are the questions in your pre-test. Total deaths 54.6 million because of cardiovascular disease. Nearly 1/3 are because of the cardiovascular disease. That's very frightening. ISD 9.5 million. See, 10% because of the stroke, rest all are because of the ISD. So it's a very frightening scenario. 1/3 of all deaths because of cardiovascular. Indian scenario is more frightening because we have a high because of our population. The percentage is the same percentage is calculated. We are very high because of high population, very high numbers, and because of our economic status, very high burden to economic burden to family and the nation. Now this is a very important. I like this slide. See, this is a very good slide. If you see, now this is 1990. I just help you to understand this slide. This red, this is the ratio from communicable diseases to non-communicable diseases. Okay, infectious diseases to non-infectious diseases. This is the ratio. This ratio was favoring infectious diseases in 1990. So most of the states in India, except Kerala, they had a very high incidence of communicable infective diseases. This was 1990. See in 2016, from everything from red and yellow has turned to blue. So over last what 25 years from infective we have become a communicable disease. Yeah. See, everything in blue. Very high communicable disease, lifestyle diseases. Ischemic heart disease, stroke, diabetes, hypertension. From infective diseases to this. It's very frightening. So we don't know, but this is how epidemiology just guides us how we are going. This is statistically CVD leading cause of death in India. It is 28.1%. I think this was one of the questions in your written. So this is the leading cause of death in India. So this is it. ISD contributes so much, stroke contributes so much, but ISD is the predominantly, then other come way down. Okay. Stroke incidence we will see here is compared to the ISD level. ISD you know around 6 to 8, 8 to 10, that sort of it. This is really, you can say 0.1 to 0.15, relative best. But Indians compared to Western countries, the incidence is higher. Young age of stroke in Indians also is lesser than the Western countries. Mortality, rural are at disadvantage. This we all know is similar to ischemic heart disease. Now this is another very important, interesting slide you will see. What causes most death? Again a comparison. 2005 ranking, 2016 ranking. What causes more death? This statistics is very, very interesting. See, besides our usual clinical this thing, ischemic heart disease has maintained its position as one. But see, COPD is climbed up, diarrheal diseases are going down, so infective diseases are going down. All lifestyle diseases, cerebrovascular disease going up, diabetes going up, kidney disease going up. All lifestyle diseases they are going up. Infective diseases going down. So this is very interesting. Don't you think this epidemiology helps us guide how the scenario is changing year to year? This is what is called as an epidemiological transition. Epidemiological, most of things, see what were common in Western countries in 1950s and 1960s are becoming common to us now. This is because what is called as an epidemiological transition. Because the lifestyle which changes which are occurring over these years, industrialization, urbanization, changing food habits, we have now more fast food, urbanization going from rural to urban, lifestyle changes, more fast life, more career oriented, eating fast food rather than the raw foods, going away from the nature. These are all epidemiological transitions. And so the disease pattern is changing according to that. So earlier, infectious diseases was the major thing. Now the lifestyle diseases are contributing. So this is the gist of this slides. Now these factors you all know. These are the behavioral risk factors. Let's go back to diet, Parkinson, modifiers, non-modifiers. I don't want to you. Most of you are physicians here, you know. Now this is again certain important information you get from these risk patterns. Now these are very important, what to say, take home messages will you see. Risk of the disease changes continuously over the entire range of exposure. That means a particular smoking 2 cigarettes is more than 1 cigarette, 3 cigarettes is more than 2 cigarettes, BP of 120 is more than 110. It is a continuous risk. So there is no a particular threshold at above which it is suddenly harmful, below which suddenly it is useful or it is not harmful. It is not like that. The risk is continuous. That one has to understand. It is a continuous risk. No specific threshold. This is especially true for blood pressure, smoking, cholesterol. However, there is a U-shaped relation or Z-shaped relation in behavior risk factors like blood pressure. You know, if you bring the blood pressure below 110, certain trials have shown that there is increasing mortality. This is what a Z-shaped curve, all these things. This was a very controversial maybe 10-15 years ago. But subsequently what it was found that Z-shaped mortality is not because of decrease in blood pressure. This was because of the particular drugs, and those were the thiazide diuretics which were given that time. Because of them, there was electrolyte disturbance, hypokalemia and arrhythmia. Most of the deaths were because of the arrhythmia. So that contributed to increased mortality. So it was not actual they say because of the reduction of blood pressure. So that is a bit controversial gray area. But lower the better stands true. Now this is again an example of continuous risk. You will see systolic blood pressure as it increases, diastolic blood pressure as it increases, the risk increases, CHG mortality. It is a continuous risk. Okay. Now this is another thing which you have to know. Is most of the events they occur moderate risk. This is a slightly different from your conception. See, what we believe more than 350 cholesterol urea. No, most of the events occur in the range of cholesterol around 250. That's what most of the people have. So most of the events, overwhelming majority have a moderately high risk factor level, not a very high risk factor. So this is, we have to change our thinking. So you have to treat moderately high is more risk factor. Don't look at more than 300. That's the thing, the message you should take home. Now, multiplicative risk. This is again very important. This is again very important in the sense that if two more risk factors combine together, the risk is multiplicative, not additive. The example here is, now cholesterol of 245 BP of this and non-smoker, now cholesterol of 220 means cholesterol is slightly less. Systolic BP slightly more and a smoker. Now the risk is 5 times. See, hardly any difference between these two cholesterol. Yes. So addition of multiple risk factors, the risk is 5 times. So you not only don't I treat a risk factor in the isolation. That's the message. The patient has a diabetes, just don't take care of diabetes. That's not going to do much good. You have to bring down his blood pressure, you have to bring in his lipids, yes, to stop with it. Then only this is going to go down. Because many of our patients, they complain, mother sugar income, heart attack. The other things are probably contributing, which we are not paying attention to. Okay, so this is more important. It's a multiplicative risk. That is very important. Now, absolute risk. Now, this is a combination of continuous and multiplicative. This is a both combination of both. This is the same thing. Means the risk is continuous and it number of risk factors they add to it. So, now the absolute risk. Now, this is an example of absolute risk reduction. Now, you have blood pressure here, cholesterol here. Now, because of the additive and multiplicative effects of each, see the risk with just 142 systolic blood pressure. This value should not be in millimoles. So this is around 250 cholesterol. The risk is so high. So cholesterol not very high, BP not very high. The risk is very high. This concept you have to understand. So don't treat any risk factor in isolation. You have to treat them together. And just treating one risk factor is not enough. So, in summary, risk operates in continuous manner, not across thresholds. Most adverse events occur in people in mid-range of risk factor. Remember. So, just BP of around 150, 160 systolic, risk cholesterol of around 240, 250 total cholesterol. So, that's where the maximum risk occurs. And in all population, majority are in person with moderate elevation of many risk factors. That individual with high level of a single risk factor. Okay, so only if cholesterol is more than 350 and if everything else is normal, he doesn't carry that much risk. But if he has multiple risk factors, that carries more risk. I think maybe we'll take a break, tea break, and then we'll go for the next session. Okay, we have seen these are modifiable, non-modifiable, behavioral. It's all we know. That we won't go into details. Everyone of you know this. Now these are novel risk factors that just requires a brief mention. Now you must have heard of lipoprotein little a, what it is called as. Now lipoprotein little a is a genetically determined lipoprotein. In fact, this carried a very high enthusiasm maybe 10-15 years ago when he showed that Indians have a very high incidence of LPA. This is called LPA, lipoprotein little a. And that's why Indians are at more risk of cardiovascular disease. Now this is genetically determined, so we can't change it. So the only treatment, if you have high LPA more than 30, is considered to be a risk factor. Okay. So if you have the only way you can reduce that, it is believed to be 100 times more atherogenic than LD. LPA is 100 times more atherogenic than LD. So that's what Enas, that was the acronym, Enas A. So he was a very strong proponent of LPA theory. And the only way we can reduce the risk conferred by LPA, if someone who has a very high LPA level, is by drastically reducing LDL. That's the only thing. You can't alter LPA because it is genetically different. So, but only you can know whether, just measure it and know whether, especially young infarcts, we measure it and see if that is conferring a risk. And here you have to be more aggressive in lipid reduction. That's all. That's the only thing which you can do. Now, HSCRP, you know, is an inflammatory marker. It's got the boost after Jupiter trial, where they showed that those who had high sensitivity C-reactive protein benefited the most. But still, one of the theories of atherogenesis is because of the inflammation. And it is said the beneficial effect of aspirin is because it is anti-inflammatory effect. Similarly, the beneficial effect of statin is not only because of cholesterol reduction, because it has an anti-inflammatory action. So, inflammation definitely plays a role in atherogenesis. There is no doubt about it. Now, this CRP, whether it is a marker, whether it contributes to atherosclerosis, that is not known. Now, it is a very non-specific. You know, CRP gets elevated in all the infective conditions, all inflammatory conditions. So, it is a very non-specific. So, HSCRP more than 3 is considered to be a risk factor. But you have to know that a single value of HSCRP never take it as a risk factor. You have to measure it at least 2 weeks apart. And if it is more than 3, then only consider it as a risk factor. Okay. Similarly, if there is an infection, you have to wait for at least 1 to 1.5 months after infection to measure HSCRP, being non-specific, but still it's one of the markers. Now, genetic polymorphisms, there are certain genetic polymorphisms have been shown to be distinct, but that still has not given us a definite answer. Now, this is a Barker hypothesis. David Barker, a UK epidemiologist, he came out. See, UK has a NHS system. You know, every patient is there registered. Every person, not patient, every person is registered there, and they have a system. If you have a disease, you have to go to your general practitioner first, a particular general practitioner. You just can't go to a specialist. You can't go to a super specialist. You have chest pain, you go to general practitioners, he refers to a specialist. If he thinks it is worth referring, you can't just say. In fact, I have many patients who come from UK, get their investigation, say, one of my patients, in fact, one doctor, they have undergone angioplasty in 2002. For 10 years, their ECG also was not done in UK. Even ECG, they themselves are doctors. They say, if I go to my GP, they say, what is the need of ECG? You don't have any symptoms, I won't do your ECG. So that sort of thing is there. So that's a very structured system there. Forget about what its drawbacks and all, but that's a structure. The advantage is they have massive data. Right from your birth to your death, everything is recorded. Okay, so they have a very massive data in NHS. Now, this David Barker came out with a hypothesis that the babies who had intrauterine growth retardation, those who were premature and those who had low birth weight, they had very high incidence of lifestyle diseases like hypertension, diabetes, and in their adolescence and adulthood. So if you are a premature, if you have a low birth weight and intrauterine growth retardation, there are very high incidence of ischemic heart disease in elderly. And this might hold true in India because most of our mothers are malnourished. We have IUGR very common, and perhaps that's one of the reasons perhaps we have more discrimination. So we have to just see. You know Dr. Yadnik from Pune? He has come with that YY paradox. you must have known what is the YY paradox. He has very elegantly shown that your body fat and your weight doesn't match. Your visceral fat and body fat, they are totally mismatched. Your visceral fat may be high. Means if you take an Indian baby and if you take a UK baby, both may be of similar weight. But Indian baby has a high visceral fat, and that probably is responsible for high prevalence of ischemic heart disease in Indians. So these are some interesting concepts which you have to be looked into. Now homocysteine. Now homocysteine again is again 10-15 years ago it was carried a lot of enthusiasm, and everyone in fact I also used to measure homocysteine in every young infant. But subsequently what happened is, yes, many patients we found high homocysteine, and homocysteine does lead to thrombotic event, there is no doubt about it. But all the interventions which attempted to reduce homocysteine did not reduce ischemic events. In fact, in some events, the events had increased. So we don't know homocysteine is a causative or it is a marker. You understand the difference? Causation marker. I'll give you one more example. A recent example, perhaps you will not, you will be surprised. We all know that HDL is a protective. Higher the HDL, you get protection from ischemic heart disease. This is a well-known phenomenon. But till date, all interventions which have increased HDL have increased mortality. Now there have been various theories saying that the mortality is not cardiac because of suicides, something else is happening, something else is happening. The fact is, HDL is a marker. We don't know whether it is a causative or it is a marker, like CRP. Just in ischemic heart disease, it is low, that's all. But whether it contributes to atherogenesis, we don't know. Whether it confers protection, we don't know. Means as of today, maybe some trial will come tomorrow and show increase in HDL will be beneficial. That might show. But as of today, most of the drugs which increase HDL, they have increased mortality. So no HDL increasing drug has come into market, unlike LDL reduction. So this is the thing. So similar to homocysteine, the same thing. Reduction of homocysteine has not decreased the risk. Okay, though homocysteine is, we know high homocysteine is a thrombotic. So these are the novel risk factors. Now this is, perhaps we all know, tobacco, diabetes, hypertension are nearly equivalent. They increase the risk 2 to 3-fold. Odd ratio or risk relative risk is 2 to 3 times. Improper diet and physical inactivity. Remember, this is interesting. It increases by 50%. Others by 10 to 50%. Now some genetic risk factors like hypertension, too much stress. Risk is 5 to 10 times, but it's very rare. We hardly see genetic hyperlipidemia. So we should concentrate more on things which we see. So this is okay, this is okay. Now these are the various scores. I think this was one of your pre-test again a question. So these are the different scores which you see and measure. These are computerized. You don't have to mug them. You just, there's a calculator, online calculator. You feed a particular value and you get the risk. Now the commonest used nowadays is Q-risk. Framingham was old, but the robust. You know how the concept of risk factor came? The concept of risk factor came because of Framingham heart study. What is Framingham? Framingham is a small town in US. In 1945, the population of that town was somewhere around 5,000 in 1945. So what this study did is they studied all the people in that town. Framingham heart study is what? They studied all the people in that 5,000 people in that town. They measured their blood pressure, they measured their sugar, they measured their cholesterol, they measured their habits, smoker, non-smoker, and everything, height, weight, BMI, everything they measured. And they started following up these 5,000 people over the years. Then some of them got married, had sons, they included them in those studies. They started expanding. And over the years, they analyzed. They still are analyzing. Today also the Framingham cohort is being analyzed. How many of smokers developed heart attack? How many who had high BMI developed diabetes? And most of the things what we know today is because of this Framingham cohort. This risk factor concept came because of the Framingham. Out of them, how many developed this thing? These are high chances of. So that's the Framingham. So very
early, robust and very good. The problem is why Framingham score is not reached a standardized score today is perhaps it has not included, it includes only 4: age, cholesterol, smoking status and diabetes. Only 4 this thing. It doesn't include other factors. Second, was restricted to American population. So we don't know whether it is now India where we don't have very high cholesterol. We don't know. So it may not be applicable in others. So that's why this score is less used. More nowadays used is this QRIS score or WHO IC. These are the more used, but you can use either of the scores if you want to calculate the risk in a particular individual in deciding whether he needs a primary prevention strategy. Statin, suppose, like that. Because now you know the statin guidelines. Now we will come to that later. Now these are the case studies. You have to go online and see, feed to any of the scores and get the risk. I won't go into this thing. You have to go online and study the risk. These are smoker. These are the risk factors. I won't go into detail. Now again some epidemiology here. Now prevalence of risk factors in established CAD. Now this is the Asian data, so more important to us. See, general CAD, not only infarction and this thing, all CAD is you have 60% nearly dyslipidemia. Means all CAD if you take, the prevalence is dyslipidemia, smoking is the highest, followed by hypertension. This is prevalent. I am not saying attributable risk. Remember, this is the prevalence. All CAD, how many of them have this thing? Diabetes, this much, central obesity, this much. So these 3 are more prevalent in Indian population. Remember, dyslipidemia, no, this is a peculiar dyslipidemia of Indians. Smoking and central obesity. So this is the thing. And the other risk factors in Indian patients now we know. Now this alcohol carrying the asterisks that we will go into detail later. The physical inactivity, low fruit and vegetable intake. Okay. Now this is in STEMI and NSTEM, the prevalence of different risk factors. So around 1/3 of them are diabetics, around half are hypertensive. If you in any ICU patient, if you see the ICU patients, analyze the epidemiology. So 1/3 are smokers, half are hypertensive, 1/3 are diabetics. Previous infarction this much, previous stroke 2.2%. Now this is, we saw earlier the risk factors before the development of coronary artery disease. Now risk factors in established coronary artery disease. This is in addition to the earlier risk factors, left ventricular dysfunction, extent of coronary artery disease, peripheral vascular disease, functional capacity. These are the myocarditis. Again, we won't go into details of this. Just we have to know them. These are the risk factors or established. This is a specialized field, so I won't go into details of that. Coming to individual risk factors. Now this epidemiology is very interesting here. Now 1.13 billion individuals with hypertension in the world. 8 million deaths worldwide each year are due to high blood pressure. 8 million deaths. That is 13% of annual global deaths. Blood pressure is the number 1 risk factor for death and disability. I think that's the one of the your pre-test this thing. So blood pressure is number 1 risk factor for death and disability in the world. Okay, so blood pressure is the one we should not underestimate. In India, incidence is nearly 1/3 in urban areas and 1/5 you can say in rural areas. So higher in urban areas. And it contributes to 16% of ischemic heart disease, 21% to peripheral vascular disease, 24% to AMIs, and 29%. So more contribution to strokes. Remember, always hypertension is a more risk factor to strokes, not that much to ischemic heart disease. Remember, number 1 complication of hypertension is heart failure. Number 1. Followed is strokes. And ischemic heart disease comes way down. The attributable risk of hypertension to ischemic heart disease is way down. For stroke, it is high. Remember, so by treating hypertension, you have to remember, you are going to prevent heart failure, prevent stroke, and less likely to prevent ischemic heart disease. Remember,
The attributable risk of hypertension is less in ischemic disease. Heart failure is number one, hypertension number two, stroke number two. This is it. Now these are the interesting. You see, the average blood pressure from 1942 to 1997 across. See, the mean blood pressure is increasing from 120 to 130. It has increased over for 50 years. It's not a much increase, but the trend you will see, the mean blood pressure in India is increasing. It's not dipped any time, so it is increasing. So it is definitely has to do something with our lifestyle changes. It's a lifestyle disease and something needs to be done. Now another thing, this shows the difference between rural and urban. Definitely rural are disadvantaged. Definitely, whether in awareness, urban awareness is more than the rural awareness. Treatment also, urban is more than the rural. BP under control, urban is more than rural. Naturally, this awareness, naturally this has to be urban. They are more aware, health conscious. Naturally, everything favors urban. Now again, as the systolic blood pressure, the lower the better, what I told you. As the systolic blood pressure increases, the CV mortality risk increases. So it's a continuous risk. So the risk is fourfold if the BP increases to 155 by 95 from 150 to 175. So 30 to 40 milliliters BP increases the risk 5 times. So that's quite alarming. This is the point which I wanted to tell you. In heart failure, see, in heart failure, the maximum contribution is because of the hypertension, the attributable risk. Then hyperlipidemia, then tobacco use, diabetes, alcohol, CKD, prior infarction, stroke. So hypertension, heart failure, the commonest cause is hypertension. Remember, heart failure, the commonest is hypertension. So by treating hypertension, you hope to prevent heart failure first. Again, same message. Coming to next, diabetes. About 2/3 of deaths in people in diabetes are attenuated severity. Now, as against hypertension, diabetes have very high prevalence of ischemic heart disease. So, diabetes, 2/3 in diabetes, the mortality is mainly because of cardiovascular disease in diabetes. So, you have to make every effort to see whether there is an occult ischemic heart disease in diabetic patients, whether they are symptomatic or non-symptomatic. Diabetes leads to risk equivalent to aging 15 years. So you increase the patient's age by, if you have a diabetes, your age is 15 years more than the general population. 1/3 of patients presented with mitral infarction have undiagnosed diabetes. Remember, undiagnosed, they present with diabetes for the first time when they have, which we see many times in our ICU, that when they are come with infarction, the first time their sugars are high. Patients with MI and diabetes have worse infarction. At every stage, they have more extensive coronary artery disease, they are more likely to do angioplasty or bypass, they are more likely to have mortality, they are more likely to chances of restenosis after angioplasty, they are more likely to have graft failure after CABG. So diabetes at every stage confers risk, from development of ischemic heart disease till the treatment failure. So everywhere diabetes is a very bad disease to have. Now this is graphically a pictorial causes of mortality in diabetes. 55%, more than half, is contributed by heart disease. Other cerebrovascular disease, 10%. So you have to make every effort to see if there is a heart disease in diabetics and regularly investigate this patient for heart disease. Now here, average age of 60, the mortality, if you don't have diabetes or MI, the mortality is around 6.8%. If you have diabetes, your mortality nearly doubles, more than doubles rather, 15.6. It is same if you have MI. So mitral infarction mortality and diabetes mortality is same. So diabetes is called as coronary equivalent. So if you are having a diabetes, that means it is equivalent to having a ischemic heart disease. It is called as a coronary equivalent. You have to treat them at par. But if you have both, see, suddenly the mortality increases. So 12 years of reduced life expectancy if you are both.
So 12 years you reduce if you have diabetes and not. Quite frightening. Now this is again a worldwide global scenario of how the disease is going to change. Means diabetes is going to change. It's not what has happened in future from 2017 to 2045. Only concentrate here this part. In Middle East and North Africa, the diabetes incidence is going to increase by 110, more than twice. In Africa, again it is 156, so 3 times. In India, 84%, nearly twice. So these are the areas where the diabetes is going to be a real epidemic. Developed countries less so. In America, less, around 35%. These are the areas which are alarming the next few years, and this diabetes is going to reach epidemic proportion. Now, this is total number of adults with diabetes, how it has increased from 2000 to 2015, how it has increased in millions. This is, I think, number is in millions. 151, 194. This is just graph is just increasing. There is no dip in the curve at all. It is just increasing. Again, rural urban. 2/3 of people with diabetes live in urban area. Again, I told you epidemiological transition. Urbanization is the one major contributing factor for development of lifestyle disease. So 2/3 of people with diabetes live in urban area and will be increased to 3/4 by 2025. So 75% will have diabetes in next 20 years. Frightening. So this is again how it has increased. See, from 1989 to 2004, it has doubled. In 15 years, it has doubled. Diabetes prevalence has doubled. Similarly, the lifetime risk of CHD graph is nearly vertical. Any risk factor doesn't have that vertical graph. The graph is like this. See, so vertical graph. That's it. As the age increases, the risk of having a coronary artery disease dramatically increases. Every year contributes to nearly doubling of the risk, both true in men and women. So diabetes confers the highest lifetime risk for CHD for any risk factors. So you have to be very careful in diabetic patient in identifying the CHD and treating it. Now, how does diabetes cause ischemic heart disease? That we'll see now. Insulin resistance. Now, many times I've seen, you also must have seen the patients. If patients come for high triglycerides today, and 5 years later you see them developing diabetes. You have hypertension today, maybe 4 or 5 years they develop diabetes. You have diabetes today, 4 or 5 years later they develop hypertension. So there is something common to all this. I always thought there is something common to this. And this common thing could be insulin resistance. And this is what contributes to what is called as a metabolic syndrome. So what are the components of metabolic syndrome? Is a glucose intolerance, that is diabetes, hyperinsulinemia, hypertriglyceridemia, low HDL level, hypertension, central obesity. I think this is also a pre-test question. So these are the components. So many times you see insulin resistance manifests in one of these. Sometimes it can manifest as a diabetes, sometimes it can manifest as hypertension, sometimes as obesity. But central at the core probably is insulin resistance. And that probably contributes to this disease pattern. And that because high insulin itself, you know, is atherosgenic. And these are the different mechanisms of atherosclerosis in diabetes. Infection, inflammation, hyperglycemia. So hyperglycemia is just one part that you have to remember. So just getting sugar under control, that does not mean that you are taking this ischemic heart disease risk under control. You have to control other factors also, especially dyslipidemia, blood pressure, smoking status. So everything needs to be controlled, and then only the diabetes risk of ischemic heart disease is going to come down. Coming to the next risk factor, lipids and CVD. Now, again, in Asians, slightly we have this different sort of dyslipidemia. We don't have very high LDLs. only 43% have LDL more than 130. So majority of Indians have low HDL and elevated triglycerides. And LDL is low to normal. That is cut here. LDL is low to normal. So you don't think that you will see very high LDL levels in Indians. So this low LDL itself is harmful to Indians because they have multiple risk factors and they have low HDL and a high triglycerides. So you have to treat this critical dyslipidemia of Indians. So we have a slightly different. So we do not follow the Western standards here. We may have to have our own standards in treating lipid. If you have a high triglyceride, along with the LDL of around 120, 130, okay, you treat. Or if you have a high triglycerides with hypertension, you treat that triglyceride aggressively. So one more risk factor, triglycerides by themselves in no trial have shown to be a risk factor. By alone, remember, I think that will come here somewhere. So control of dyslipidemia is poor even on developed countries, 90%. Now this is the data, 90% prescribed statin and discharge, only 86% taking at 1 year. The high statin dose continues to decrease, people don't take high dose, maybe because of cost. And 12% they discontinue and we don't achieve our Indian targets. That's what is the statistics say. Now here you will see, as the cholesterol is again continuously, as the cholesterol level was increased, at every age the risk increase, every age group, especially 40 to 49. This is the dangerous age group where the risk of increasing cholesterol is more. This is the main, I think we see many patients in this age group. Many Indians develop infarcts in this age group. So this is the age group where we have to be more aggressive in treating risk factors. So this is same thing as HDL, this thing, increase in non-HDL cholesterol, same continuous risk. So lower the better, that's the concept. Stroke mortality, lower stroke level is associated with lower risk of ischemic stroke, but no clear association with hemorrhagic stroke. We saw one trial. The probabilic hemorrhagic stroke, slightly LDL reduction contribute to increase in hemorrhage. But ischemic stroke, definitely you are going to reduce with the bringing down the LDL cholesterol. So this we saw, LDL cholesterol reduction is important. This is again LDL cholesterol decrease HDL. You see this. Now triglycerides, this is what I was mentioning. Triglycerides are very often they are associated with insulin resistance. This is what I told you, is associated with insulin resistance and dysglycemia, abdominal obesity, so typical metabolic syndrome. That's what we get with the high triglycerides. And associated with CVT and setting in observational setting, clinical trials show mixed results. Independent reduction has not shown any significance. So triglyceride reduction by themselves have not shown to be useful in predicting CVD mortality. Only one trial has shown that if triglyceride is more than 500, then its reduction is definitely useful. One. Second, in women, perhaps triglyceride reduction is useful. Two. Then why do you treat triglycerides reduction? The thing is because of pancreatitis. Okay, so high triglyceride can contribute to pancreatitis. So treatment of high triglyceride level you have to treat. And if triglyceride is associated with low HDL, high LDL, other risk factors, then definitely you bring it down. Definitely, and use the, now you know the statins are not the best drugs to treat triglycerides. Okay, so if you have only triglyceride elevation, HDL you may have to give different, that we will come to dyslipidemia as a separate module I feel. So we'll see it there. So this is. So triglyceride may be important presence of low HDL level in Indian patients. So in Indian patient perhaps you have to have low, perhaps I think this is low HDL. Probably this is a typing mistake I think. Maybe important presence of low HDL. I think this is a type I have to convey it to them. I don't think it is low HDL. Okay. Coming to tobacco and CVD. Smoking is the leading preventable cause of disease, disability and death. 100 million deaths in 20th century, estimated 1 billion deaths in 21st century. We know all this. Nearly half of men and 15% of women use tobacco. And 1/3 of South Asian patients of MI, they are smokers. So smoking we know is very common in our country. Very common, especially smokeless tobacco. Now, what causes death due to smoking? Now, these are the different diseases which are because of smoking. COPD, CVD, that is what our current topic, cancers and other infections. Out of CVD, more than half are because of the coronary artery disease and rest are because of stroke. So smoking nearly contributes half, 53% because of the ischemic heart disease is because of the smoking, and more than one third, the stroke contribution is because of the smoking. So that's the global burden. So the smoking, and this is the definitely truly preventable, totally avoidable cause for cardiovascular disease. Now we know it comes in different shapes and forms. It's all to some extent, all are harmful. All are harmful. Now this probably is as such of advertised. The young Indians are carried away by this advertised. Now smokeless tobacco. This is what is common in our population. Smokeless tobacco. That is pure raw tobacco, that is called as khaini in and tobacco in our place, khaini in North India. Gutka. This is all smokeless tobacco. Presently, nearly 1/5 of Indians they use smokeless tobacco, that is the gutka or tobacco proper. 15% pan masala, 14% cigarette, 13% in women also. And this is khaini is same raw tobacco. And nearly 85% of smokeless tobacco is of Southeast Asia is because of India. So we are again a capital of smokeless tobacco. We can say 74% out of the total Asian population we contribute to the smokeless tobacco, and that's why I think that gutka industry is thriving in India. So that's very sad, I think. So this is one totally preventable cause of CVD. Now this is physical inactivity. Now Darwin survival for the fittest. This in true sense, those who are fit, they are less likely to have ischemic heart disease. Now this is again alarming statistics. Those who are not physically active, they spend more time in sitting. That's the data. So in Chandigarh, 88% they predominantly sit. They don't do activities. Jharkhand 94, Maharashtra 91%, Tamil Nadu 93%. Overall, only 10% of us they indulge in physical activity. Only 10%. Anirudh? So that's the data. Okay, so that's quite that's the not the good thing. Means sitting, physical activity is not that you have to regularly exercise. You have to be active, moving. Okay, not a couch potato, that sort of a thing. So that is thing. And what the statistics tell you, that the contribution of death of smoking and inactivity is same. Quite interesting. Same global deaths per year, 5.1 million by smoking and physical inactivity 5.3 million. Very scary. Very scary. Interesting slides, I think. Very interesting slides. Physical inactivity is as bad as smoking. Reduced physical activity and increased time spent sitting are both associated with total mortality, strongest for CVD mortality. And how does this physical activity prevent CVD? How? By cholesterol reduction, triglyceride reduction. This is all lipid favorable modifier, because exercise is one of the few factors which increase HDL. Okay, rather than medicines. The medicines have not shown to, although HDL has been shown to increase, it has not contributed to increase in decrease in mortality. But exercise, there are very few biological and natural methods to increase exercise, to increase HDL. One is exercise. The second is certain food products, like garlic. these are very few things which increase HDL, or otherwise there are very few things. Alcohol is one which increases HDL. Otherwise there are very few things which increase HDL. For decrease of LDL, decrease in LDL you have so many things. For increase in HDL you have very few things. So physical activity is one of those things. And this physical activity also has these co-benefits like blood pressure reduction, body fat, obesity, osteoporosis, and those things. So these are the other benefits, and in fact, we all know this. Problem is about implementation, execution. Not that we don't understand it. Perhaps the gravity we know today, but we all know it is useful, and the only thing it has to come from within to do it. That's the problem. That's the problem with me also. I'm not saying that I am a different man. That's the problem with me also. Now, it has been shown in trials, the Finnish diabetes prevention trial, that diabetes was prevented by lifestyle changes. So, those who are prone for diabetes, family history of diabetes or obesity, diabetes, then the physical activity has prevented diabetes, at least delayed its occurrence. So by proportion, this was NEJM article in 2001. So it is shown proper exercising can prevent or prolong the diabetes. Similarly, hypertension also can be prevented. So those who have family history of hypertension, those whose BP is high, in them, and you will see one interesting slide later. Yes, this is an interesting slide. Exercise interventions suggest that exercise and many drug interventions often potentially similar in terms of mortality. Means certain drugs, the degree of prevention of mortality by reduction of BP by a particular drug and by exercise is nearly the same. In other words, adequate exercise is equivalent to one drug. So if patient is taking 3 antihypertensive medicines, you can, if patient adequately exercises, perhaps you can stop his one medicine. Okay, that's the message. So much is the importance of exercise. Now coming to a sensitive topic, alcohol and CBD. Now this, I think, why I say sensitive, many newspaper articles, many doctors, everyone, subtly, they give the message that alcohol is beneficial. Right, that's a very subtle message passed even by doctors. In our groups also, that's the message goes. It's a vasodilator, it increases HDL. In fact, 20 years ago, I made an editorial in Circulation, written by none other than Rahimtullah, was a very topmost cardiologist at that time. The first sentence of that editorial I remember, he said, I owe my health to my 2 drinks at night. That was the first sentence of the editorial that time. So such things coming from a cardiologist, many newspaper articles, some trials, have always confused us, confused you, confused me, confused everyone. What is the message that we have to give to general public? Okay, so we have to put it in proper perspective. Why? Whether the alcohol should come in your prescription or it should not. That's the question. Now, low drinkers means the alcohol absolute amount less than 5 grams per day. Moderate drinkers is 5 to 30 grams per day. Heavy drinkers is 30 to 90 grams per day. Okay. I will come back to slide again later. What is one drink means? Moderate drink is less than 2 drinks per day in men and less than or equal to 1 drink per day in women. What is binge drinking? Binge drinking means pattern of alcohol consumption that achieves blood alcohol concentration of 0.08%, and that usually corresponds to more than 4 drinks on a single occasion. Absolute alcohol, 14 grams. That is by 354 ml of regular beer or 266 ml of malt liquor. I don't know what it is. Wine, 148 ml of wine, which contains 12% alcohol, and around 44 ml of whiskey, rum, or whatever it is. So this is one train. Going back to the previous slide, so you are permitted according to ACC-HA. So these are the standard guidelines. You may have less than 2 drinks a day. You can translate that into type of alcohol, which alcohol. I have not come to my final slide yet. Okay, these are just the slides which I am giving the statistical data today, which is their Western literature which you have. Okay, so this is it. What is a 2 drinks? So these are the what is this thing? Now this is the slide. See, these are the trials, inter-heart studies, sub-analysis. In all population, the alcohol was beneficial, but not in South Asia. Okay? Unlike other population, alcohol was not cardioprotected in South Asia, and odds of having MI was higher among alcohol versus non. So that is clear. Alcohol cannot come in Indian doctor's prescription. Okay, so this clearly has this inter-heart. Other, maybe because of the type of alcohol probably that is consumed in India. That could be the reason. Perhaps they might consume more wine and more, because we don't know what part in alcohol is beneficial. Whether it is the proper alcohol, the preservative that is used, the processing part, we don't know what is beneficial and what has contributed to reduction of this in that population. But Indian population, definitely the alcohol is harmful, and one has to have no qualms about it. One has to be very firm, and this will be further reinforced in this slide. In India, this is Indian men, impact of alcohol of coronary artery disease in Indian men. See, non-users definitely have less risk of CHD compared to users, occasional users and regular users. So definitely the alcohol is harmful as far as CHD in India. It has a 1.4 higher odds compared to having a CHD. In regular the odds are 1.6, and if the country liquor is used, the odds are further high, 1.8. Okay, nearly twice. So country liquor definitely is found to have highest odds of having a coronary artery disease. So I think this was a very large 19,000 patients, so a very large study, and I think this should raise the doubts about alcohol, whether it is good or bad. So the take-home message about alcohol: drinking is harmful. Don't tell anyone that moderate amount of alcohol is good. Okay? Alcohol has no role in CHD. Clear? Should we stop for lunch? तयारी आहे जेवायची? 10 मिनिटं. Now coming to the other slides of screening and diagnosis of CAD. Now having seen the risk factors, now we go to the diagnosis of coronary artery disease. Now, of course, history is important, physical examination is important, the assessment of risk factor we have seen. History is not the place to tell about the history. Now these are the various tests that are available for diagnosing of ischemic heart disease that we all know. Stress test, stress echocardiography, nuclear perfusion stress test, CT coronary angiography, invasive coronary. Now, what is the basic purpose? We want to pick up the ischemic heart disease at the earliest, so as to help to prevent a coronary event later. So we have to diagnose ischemic heart disease, and then we prevent the occurrence of a coronary event. So now this concept you have to understand. This concept, what is called as a pre-test probability. Now pre-test probability means what are the chances of having a coronary artery disease in a particular population. Now, chances or probability of having a coronary artery disease in less than 15-20 years age are extremely low. We know, and you have to have an overwhelming evidence of some investigations to tell that it is ischemic heart disease. We are not going to believe anyone less than 15-20 if he says ischemic heart disease, whatever his ECG shows. We have to see, investigate again and again and to see, because the probability of him having a ischemic heart disease of less than 20 years is extremely low. Okay. Similarly, the probability of having a ischemic heart disease after the age of 60-65 is quite high. So here our threshold of diagnosing ischemic heart disease should be low. The threshold for diagnosing ischemic heart disease in the younger population should be high, while in elder population it should be low. Similarly, those with multiple risk factors, the threshold should be low. With no risk factors, the threshold should be high. Clear? Okay. This is what is pre-test probability. So the concept of pre-test probability is important, is because any diagnostic test will operate upon pre-test probability. This I will tell you in subsequent slides. So, what is the prevalence? This is called the Bayesian theorem. B-A-Y-E-S, Bayesian theorem. Bayesian theorem deals with the pre-test probability. Means the test, positive or negative, increases or decreases the chances of a person having a disease. Okay? We'll see. You'll get this concept clear later. This is Bayesian theorem. Theory of correlation probability. Knowledge of pre-test probability, sensitivity and specificity of test performed are necessary to determine predictive value of test performance. Now, just I try to explain the meaning of this. Pre-test probability I told you. What is the prevalence in this population? That is the pre-test probability. High age group, high probability. Low age group, low probability. Diabetic, hypertensive, high probability. Non-diabetic, non-hypertensive, non-smoker, low probability. That is probability. Sensitivity of the test and specificity of the test. That you have to understand. Now, sensitivity of the test is what? Sensitive means if there are 100 patients of ischemic heart disease, if your particular test diagnoses them 90 patients of those, the sensitivity is 90%. Now take ECG. Ischemic heart disease, I am not saying myocardial infarction. Ischemic heart disease, if you how much chances of you diagnosing on only baseline surface ECG of diagnosing ischemic heart disease? Less than 10%. Most of them, if it is not infarction, most of them they have a normal ECG. So the sensitivity of a surface resting surface ECG of diagnosing ischemic heart disease is very less than 20%. The sensitivity of diagnosing acute myocardial infarction by surface ECG is 80%. STEMI, in STEMI nearly 20% on first ECG. 20% of the ECGs in STEMI, the first admission ECG can be normal. That means in 80% it is abnormal. So 80% you are likely to diagnose STEMI in your first surface ECG. The sensitivity of ECG in diagnosing STEMI is 80%. Got the point? What is sensitivity? So out of total diagnosis, how much of your test is diagnosed? If total diagnosed patients are 100 ischemic heart disease, if your test diagnosis 10, sensitivity is 10%. If it is diagnosed 20, 20%. So ECG 10, maybe around 15 to 20%. Stress test sensitivity. Stress test means exercise ECG. Sensitivity I am saying, is to the tune of 65 to 70%. 65 to 70%. Sensitivity means if there are 100 patients of ischemic heart disease, 65 to 70% will be diagnosed by stress test. But remember, so around 30% will be missed by stress test. So they might be having ischemic heart disease, but your stress test will be negative. So that's the sensitivity. This is the importance of knowing the sensitivity of
test. Coronary angiography has nearly 100% sensitivity. You see actually there is ischemic heart disease or no ischemic heart disease. Now your nuclear scan. Nuclear scanning adds nearly 10% more to your exercise procedure. So nuclear scanning, your stress thallium, what you mean, the sensitivity goes up by nearly 10 to 15% to around 18 to 85%. Similarly, dobutamine, it adds more. Now I will see when to use what. But this is sensitivity. What is specificity? Specificity means you are able to label a patient normal as normal. That is specific. Suppose a 20-year-old man undergoes a stress test. So 15-year-old boy undergoes a stress test, and if his stress test is positive, we will think 100 times. Ideally, stress test should be negative in all patients who don't have ischemic heart disease, right? If patient doesn't have ischemic heart disease, his stress test should be negative. But if stress test comes positive, even if there is no ischemic heart disease, that means specificity of that test is not good. It is not able to identify a normal person. That's bad. Means at the end of test, you should be able to tell that this person has a disease, he doesn't have a disease. Test should be such good that the ideal test should have 100% sensitivity, 100% specificity. So you should be able to diagnose all patients who have ischemic heart disease, and if a particular test is normal, you should be sure that there is no disease. That is sensitivity. Okay. It should also tell you if the disease is abnormal, definitely you have a disease. That is specificity. But if the test is abnormal and still you may not have a disease, if it is like that, that means specificity is low. I'll give you an example. The example, if you have LVH with STP changes in V6, if you subject them to stress test, that stress test comes as positive. Here, although stress test is positive, those changes could be because of left ventricular effect. So he may not have ischemic heart disease. So in this context, when the patient has ECG changes, although stress test is positive, the specificity of test goes down. As against this, if the ECG is normal, during stress test, if the changes develop, yes, that is likely to be positive. So the concept is now, we go back to what is called as a, now this is coming back to what is pre-test probability. Just to briefly revise, pre-test probability. Slightly, pardon me for the slide sequence, I can't change the slide sequence. Now, pre-test probability, what are the chances of a person having ischemic heart disease? Age group of 30 to 39, chances of men having ischemic heart disease is only 4%. 30 to 39. In women, chances are further less, only 2%. Similarly, if they don't have a, if they have a atypical chest, okay, atypical, छातीत चमकतंय, इथं असं दुखल्यासारखं होतंय, इथं दुखतंय, असे पेशंट जे येतात आपल्याकडे, इथं दुखतंय, असं बोटानं दाखवतात. So this patient, that is atypical chest pain. If they have atypical chest pain, the age group, these are the chances of having pre-test probability. These are the chances of having ischemic heart disease. Only 4% in men. Atypical chest pain, if the age is high, the chances increase to 27%. Although the chest pain is not typical, just because age has increased, the pre-test probability has gone up. Remember, this is a contribution. So you have a contribution of type of pain and the age group. If the pain is atypical angina, चालताना हात दुखतो. This is atypical angina. चालताना हात दुखतो, चालताना कान दुखतो, चालताना पोटात दुखायला लागतं वरच्या बाजूला. Not a typical angina, but it could be angina. See, the pre-test probability has gone up. 30 to 34%.
Even in women, it has gone up, not to that degree. See, women, they are more likely to have what is called as a syndrome X. Syndrome X, that means they have many times, in fact, I have done many angiographies of women. I was 100% this patient is going to, this lady is going to have ischemic heart disease. Very classical angina. जिना चढला की छाती भरून येते, थांबायला लागतं. And many of them, their angio is normal. This is what is called as a syndrome X. Syndrome X is a typical angina with normal epicardial coronary artery. This is the definition of syndrome X. Typical angina with normal epicardial coronary artery. And why there is angina? Now, if this angina you are able to prove that this angina because of ischemia. How we are going to prove this angina? Many times the stress is positive, but in women many times it is false positive. So how are we going to prove that this angina is ischemic? Do their nuclear perfusion study. During exercise, when they develop angina, if their nuclear stress test shows defects, then you know there is a documented ischemia in that area. And still the epicardial coronaries are normal. So what that does lead to you? It is a microvascular disease. Microvascular. The coronaries which you are not able to see on coronary angiogram, small vessel disease. Okay. So this is common in diabetes. Okay. So small vessel disease. So they have documented ischemia, where epicardial coronary angiogram is normal, and stress test is positive, nuclear scan is positive, but coronary angio is normal. They need treatment because they have documented ischemia. They need treatment. But if you don't, if you have angina, and if you don't have any documented evidence of ischemia on nuclear scan, then perhaps you don't need it, because there is no anti-ischemic treatment. Okay, because you don't have a documented ischemia. That angina which she is interpreting chest tightness, maybe because of something else, maybe esophageal spasm, maybe COPD or something, some other cause of chest tightness which she is interpreting as angina. Might, but if you have documented ischemia on nuclear perfusion scan, or perhaps even a significantly positive stress test, perhaps you have to give them anti-ischemic treatment. So now this is the concept of pre-test probability. So when the age increases, your pre-test probability goes up. As the pain becomes from non-angina, atypical angina to typical angina, then your pre-test probability goes up. Okay, it's from 4% in men to 76% in typical angina. So what is the basic message from this side? You have, again, same thing which I told you. You have to be extremely cautious, careful in reporting ischemic heart disease here. Your threshold should be very high, and you should have to be extremely cautious in ruling out ischemic heart disease here. So totally opposite concepts here. So this is a Diamond Forrester chart called as this is useful for stress test. This is basically for stress test. When you do a stress test, you know what is their pre-test probability. Then you do a stress test, and if the stress test comes positive, now coming to sensitivity of test. Again, slightly changes slides. Coming to sensitivity, because these all are interlinked. Pre-test probability, sensitivity, specificity. So I told you, true positive means 100 ischemic heart disease, your test is able to diagnose 90, sensitivity is 90%, and you are able to diagnose all 100, then your sensitivity becomes 100%. So out of the ischemic heart disease, out of the total patients of ischemic heart disease, how many you are able to diagnose, that tells you the sensitivity. Okay, so true positives amongst total positives. Now, why I am saying true positives among total? Sometimes, even if your stress test is positive, you report it as positive, he may not have ischemic heart disease. That is false positive. Okay, so you have positivity on one side and disease on other side. Now you have a test result, this is positive or negative, and this is present, this is absent. So this is how you use. The sensitivity is ability to diagnose true positive. That is sensitivity. Out of total patients with disease, how many tests is able to diagnose. That is sensitivity. When you are able to diagnose true negative, means the disease is not there and your stress also is normal, that is true negative. That is specificity. So you are able to, what I told you, able a normal patient who does not have disease, in him stress test should be negative. That is able to diagnose true negative. So ability to diagnose true positive is sensitivity, ability to diagnose true negative is specificity.
You cannot diagnose false positive stress test only on stress test.
You cannot diagnose, only on stress. Right, absolutely right. So that's what is important. You will report stress test as positive. Now here your next concern, what is the positive predictive value of the test? Okay, so if your sensitivity is high, specificity is high, then your positive predictive value is high. That means the reliability of the test is high, in one word. Your sensitivity should be high, specificity should be high, then the reliability of the test is high. So the reliability of coronary angiogram is very high. With confidence you can say the patient has disease or does not have disease. Right? That is the reliability. Stress test, the sensitivity is to the tune of 65-70%, specificity is to the tune of 65-70%. The reliability moderate, not very high. Got it? So that's it. As you rightly said, patient has a positive stress test. What is the further step? Whether he has a disease or he doesn't have disease. So you go to next level of investigation. Whether it is a true positive or a false positive. If the next test, confirmatory test shows that the disease is present, then that becomes true positive. Okay? So as you rightly said, true positive, false positive is a retrospective diagnosis. Right? When you further know that whether the patient has that disease or doesn't have a disease. What? So stress test is positive. You subject the patient to coronary angiogram. Coronary angiogram also shows coronary artery disease. Then your stress test was true positive. Coronary angiogram normal. Your stress test was false positive. Right? So next time when you do stress test in that patient, you have to be doubly careful. That is going to come as positive. No, what is the whether you should do or not, that's a different story. Maybe because if you don't have any other investigation, nuclear perfusion, maybe if that changes come earlier than the earlier stress test, in more leads, perhaps you can increase its specificity. That's it.
Sir, another question. If the stress test is becoming positive at 9, 10, 11 minutes, and patient is absolutely asymptomatic, and there are clear-cut ST changes, and if you see, you will label it as positive.
There is no doubt about it. If there are typical ischemic changes, we are going to label it positive. Now whether it's true positive, false positive, you have to take total context. Whether it is a pre-test probability, if it is high, then definitely you are very strong. If it is a diabetic, 55, 60 years old, you have no doubt. You will be surprised if he doesn't have coronary disease. If she is a female, 30, 35 years old female, then you will give a guarded positive, but likely to be false positive. That is your impression. Right? Only on stress test, likely to be false positive. You confirm it on next test. So true negatives you are able to identify, that's specificity. True positives, sensitivity. So this is what is predictive value. The positive predictive value of a test represents the likelihood that patient has positive has a disease. Of all who positive, that's a positive. Reliability of the test. You know this test is positive, blindly you say he has a disease. So positive. Negative predictive value, same thing. You say negative, go home. Absolutely. If the negative predictive value is high, yes, you tell with confidence that you don't have anything. So if the negative predictive value is high, you know that now you will see in which condition, which test we should do in an ideal scenario. So screening in women. Now screening in women, you know their pre-test probability is low. Okay, so 2000 women, only 6 are likely to have CAD, that is 2% prevalence. The test sensitivity is 66%, specificity suppose is 95%, then even if the pre-test probability was 0.3%, even if the stress test is positive, the post-test probability becomes 4%. Okay, because the pre-test probability was so low, even if the stress test is positive, the post-test probability doesn't go very high. So, in a patient, a 30-year-old female without risk factors, even if her stress test is positive, we are not going to give much importance to their positive stress test. Because the post-test probability is also 4%. As against this, if the pre-test probability is high, with the same stress test, the pre-test probability from 5%, pre-test probability is high, 5%, maybe around 40-45-year-old lady, 5%, the post-test probability goes to 40%. Stress test positivity with a low pre-test probability of 0.3% in a 20-30-year-old lady. Stress test positivity in a 45-50-year-old lady. See the post-test probability go to 40% from 5%. Yes, that is something we have to think. So reporting a stress test in which age group, that is important. Okay, so you have to report a test in that context of the patient. What is pre-test probability? This is a message, not only stress test. We deal commonly with stress test because we don't have any other, other tests to decide. So this is importance of pre-test probability. So this is the message. Those with low probability of CAD, that is young asymptomatic patients, have incidence of false positive and may undergo unnecessary. So if a female without atypical chest pain, 30 years, you need not go further under tracing because her post-test, even if the stress test is positive, her post-test probability is 4%, you leave her alone. Just observe, leave her alone. A patient who has high post, now suppose a patient who has a typical angina, but unfortunately stress test comes as negative. His post-test, pre-test probability around 70%. Post-test probability, even if negative, it remains 70%. It does not go down. So still you have to think of investigating further. In fact, if patient has a typical angina in a high pre-test probability of 70-year-old man, angina, diabetic, hypertensive, if he has angina, you need not do stress test. Ideally, in our population, we have to convince them why they need angiography. In an ideal way, if they have a typical angina, you can straightway subject them to coronary angiography. Need not do a stress test. So, if a high pre-test probability, you can obviate stress test and do a directly invasive angiography. A low pre-test probability, you should not do invasive test unless your post-test probability goes very high to above 30, 35%, 40%. That's the message. So, what is the message? The stress test is most important in whom there is an intermediate risk of CAD. What the point? So, the pre-test probability is somewhere in the range of 10 to 30%. Pre-test probability. Going back to that Diamond Forrester table. Yes, this table. You will see when the pre-test probability is somewhere 30%, 20%, 12%. This is it. If the stress test is positive, their post-test probability goes way above 60%. In intermediate. When it is low 2%, it goes to maybe 20%, 25%. If it is high, naturally you are going to subject them to angiography. If it is more than 60-70% to baseline. So the stress test most important is in that mid group, intermediate risk, intermediate pre-test probability, maybe around 8-10% to 20-25%. If that's the risk, pre-test risk, then that's the one who are going to maximally benefit from your stress test. I think this concept is very clear to everyone. Got it? Now this is a stress test. Now this is a typical stress test reporting. You will see stress test positive, typical reporting, downsloping or a horizontal. That I won't go into detail. Now this is the utility, a take-home message for stress test. This is usually an initial diagnostic test in most patient susceptibility that we all agree. Advantage, because not only we get ECG changes, but we see how the heart rate increases, how the blood pressure increases, whether patient develops angina during pressure. If patient develops angina, the similar message you know, yes, this is, and patient also understands it. मला चालताना छाती दुखलं होतं, म्हणजे हे बरोबर आहे. He is more likely to get convinced for angiography when that angina is reproducible. The limitations, these are the limitations. If you are left ventricular hypertrophy, what I told you, resting ECG changes. Left butterfly block, you don't do a stress test. You don't do a stress test for diagnosis. If you want to know his exercise capacity, that's fine. But for diagnosis, LVBP, always you have a positive stress test. So don't do stress test in LVBP. Paced rhythm, you don't do stress test. WQW, don't do unless you are looking for exercise-induced RMPS. Sometimes in WQW, because of increased sympathetic activities, you are exercise-induced arrhythmias and you may need emergency, means you may subject that patient to radio frequency ablation because this is a high risk for sudden heart cardiac death, especially in athletes. If they have resting WQW, you know there is sudden cardiac death. So especially while walking, if they start developing arrhythmia, you know this patient is going to have sudden death. So that's perhaps an indication for do a stress test. Because that's a non-invasive way. Ideally, in WQW, you should do electrophysiology study. What is the refractive period of the accessory pathway? If it is less than 200, you do radiofrequency ablation. If it is more than 200 milliseconds, don't do. That is not possible. At our level, you can do a WQW. You increase the heart rate. See if that delta V disappears. If the delta V disappears with increase in heart rate, you know it is a benign WQW. Okay. If it doesn't develop arrhythmias during stress test, it is a benign WQW. That's our way. So if there are resting ECG changes, resting WQW, resting pacemaker, paced rhythm, then stress test is not indicated. You should not do stress test. Stress test has no value. Now here when stress test, exercise test doesn't have a value, the other investigations come into play. One is stress echocardiography. Stress echocardiography is either you make the patient walk on a treadmill and then do his echo at rest, echo at peak exercise and see for regional wall muscle abnormalities. Or if the patient is not able to exercise like in orthopedic problems or strokes, then you give him lobotomy, increase in heart rate and blood pressure and go on sequentially doing his echocardiography and see if there is any regional wall muscle abnormalities. Now, it also has its problems that we will see. So wall motion abnormality, new wall motion abnormalities, if they come, you know there is ischemia. Wall motion abnormality at rest that do not change with exercise indicate infarct. Okay, it is a scar, so it is not going to change. It's not a dynamic thing. So now this is how a stress echo, now a contrast was injected here. Unfortunately, this image is cut here, but you will see this is at rest and during stress. There is a black dot here, because the contrast has not reached here during peak exercise. So that's the ischemia here, the dark area here. This is during diastole, this is during systole. So this is a stress echocardiography. Now, how it is useful and when it should not be done. Utility when baseline ECG is abnormal, like the conditions which we saw, or when information on particular myocardium is needed, you want to know which territory is ischemic, which is infarcted. You have an angiogram. You have LED 100% occluded, RC 100% occluded. Now you want to know whether you want to subject that patient for revascularization, either as CABG or angioplasty. Now there is a scar in myocardium. Now if that scar remains after dobutamine stress test, then revascularization is not going to be useful. If there is resting, no change in a particular territory, LED RCA territory, and it develops ischemia during stress test, you know revascularization in that territory is going to be useful. So if RC revascularization is going to be useful, you can just do angioplasty. Why subject him to risk for CABG surgery. So that sort of localization you can have in stress echocardiography or also in the nuclear scan. So that is the other thing. And you can measure PA pressure, you know valvular condition, because sometimes the stress test is positive. You do echocardiography, there is mitral prolapse. Okay, so mitral prolapse is one cause for a false positive stress test. So you are taken back. Now you have reported stress test is positive, now there is APP. Now that could be false, you are guarded now. Okay, in such conditions maybe you go for dobutamine echocardiography, stress echocardiography and confirm whether there is a visual wall visual abnormality after injection of dobutamine. So what are the limitations? Advantage is you have everything data, you see actual. Limitations, suboptimal image quality. Many times you don't have a good image. And this is very subjective, basically. Very subjective. You have to believe a cardiologist. He says there is hypokinesia, you have to believe it. That's all. In ECG, you see the ECG for yourself. Where there is ST depression, where a doctor has reported is positive, you see you are for yourself, where there is ST depression. In echo, you have to believe it. There is hypokinesia. That's all. That's the difference. Okay. Now, that's why there is subjectivity in echocardiography. And there is objectivity in stress test. You see ECG there. This wall motion abnormality is always a problem. It is a subjective. I feel there is hypokinesia. Someone feels there is no hypokinesia. That's all. A subtle hypokinesia and experienced echocardiographer picks up. A new echocardiographer doesn't pick up that mild hypokinesia. So that's it. Then if it is a multi-vessel disease, if the specificity is high, it is more likely to diagnose. But if there is a single vessel disease, then perhaps stress echocardiography may not diagnose. So the specificity is less. Sensitivity also is less. Okay, that's it. So nuclear perfusion, similarly when the resting ECG is abnormal, then where you can't do a stress test. Here radio tracer like technetium is injected at rest, then second injection is given at the peak exercise. And then the images are taken. Then you see the difference at rest and at peak exercise. Now this is this thing. So this is a stress image and this is at rest. So this you can see full filling here. And there is a defect here. You don't see any yellow thing here. So that's a defect at exercise. So this is this probably this defective. There is what is that? Technetium has not reached here during stress test. So you know this area is ischemic. And so you can localize also which part, whether it is a septum, whether it is an inferior area, the lateral wall, depending on that which coronary artery territory. So you hear this is more objective than a dobutamine echo because you can accurately see it. So it is more objective. And simultaneously you have a stress ECG also going on. So when baseline ECG is abnormal and when a particular localization value that you have in nuclear scan. Advantage, imaging acquisition coordinated with cardiac and use of high-end techniques and techniques use correct for attention, that's okay. Limitation, you have some artifacts like great tissue artifact, diaphragm and radiation exposure and availability, main. It's not freely available everywhere, that's the main, and the cost involved. These are the main limitations. This slide doesn't mention, but that are the practical limitations. Now CT angiography, now it's coming, you see every patient asks me, when I recommend them angiography, they say I will do CT angiography. So this, you have to know what is CT angiography. CT angiography, it gives anatomical information. It uses iodinic contrast like our coronary angiography. And I will see, it has its advantages. Not that it doesn't have its advantages, it has its advantages. Then you use CT angiography. First, before you do CT angiography, you see the calcium. That is called as CAC, calcium scoring. Now, calcium scoring, higher the calcium scoring, what calcium scoring tells you is the burden of atherosclerosis. It doesn't tell whether there is stenosis. Okay, you may have very high calcium score, more than 1000, but there may not be narrow, any coronary artery may not be narrow. It doesn't tell you about the lesions. It does tell you there is atherosclerosis. So, calcium scoring is useful for prevention strategies. Means if there is a calcium scoring, if the calcium score is high, this patient needs aggressive preventive strategy. Give him statins. Tell him dietary therapy. Tell him exercise therapy. So he needs to have a prevention of ischemic heart. This is a sort of a secondary prevention. So calcium scoring does not tell you about coronary lesion. 70%, 80%. No, it is for a epidemiological purpose. Higher calcium scoring is he has high degree of atherosclerosis and you need to have prevention measures. But CT angiography, when you inject a dye, calcium scoring is without injection of a dye. Okay. In fact, if calcium score is very high, more than 2000, you cannot do CT angiography. Okay. If calcium score is very high, the coronary image by CT angiography becomes uninterpretable. Remember. So before CT angiography, you always do a calcium scoring. If calcium score is only low, then you go ahead and inject the dye. So this is one of the limitations of CT angiography. High calcium calcification, you cannot do CT angiography because the coronary image becomes uninterpretable. So if there is high, then that gives you an information about preventive strategies. Okay. Now CT angiography. This just briefly the summary. This is very useful in anomalous coronary artery because in coronary angiography, if you are not able to see a LAD in a particular place, circumflex in a particular place, cath lab is not a proper place to trying to hook where and look for coronary artery where it is arising from. You don't know where it is arising from. Sometimes it arises from right coronary, sometimes it arises from non-coronary sinus, sometimes rarely it arises from pulmonary artery. It is not possible, physically possible to check every area. But CT angiography tells you beforehand if it is abnormal coronary artery, abnormal collision. That's one very good advantage of the CT angiography. Okay. Then you can not only you see coronary, see in standard coronary angiogram, what they say is coronary angiogram is a luminogram. You see only the lumen of the coronary arteries. Standard invasive coronary angiography. You don't see the vessel wall. That's the disadvantage of our conventional angiography. In CT angiography, you see the vessel wall also, lesion also. Vessel wall, whether how much is there is actual plaque and how much is the lumen. That's the advantage of a well-done CT angiography. Okay, that's the advantage. And the limitations is a requirement of ICT. Now, practical limitations and advantages I'll tell you of a CT angiography because I am facing that question day in and day out. One is our subjective nature of CT angiography. Many reports you will see, especially this Sahyadri group diagnosing, many of them they report it is positive and you don't have coronary. Subjective. So you have a very good radiologist who reports CT angiogram properly. Then only you have to rely on them. The practical value of CT angiogram is what? If CT angiogram is normal, then you can be 100% sure that you don't have coronary disease. That's the most important thing. So it has a very high negative predictive value. If CT angiogram is normal, definitely you don't have coronary disease. That's the most important thing. So, say a doctor, usually the doctors, they are worried whether I have coronary disease, I don't have it. They don't have any symptoms, they don't have any symptoms. But day in, day out, they are seeing the patients with coronary disease and they feel I am likely and they are. So for that person, when the pre-test likelihood is around 20-25%, you subject them to CT angiogram. And if CT angiogram is normal, okay, he can be assured that he doesn't have coronary disease. The problem is if CT angiogram is abnormal. If CT angiogram shows 20% lesion, it can be 80% also. The severity of the lesion is totally misdiagnosis. If it says 80%, it can be 20%. In both ways. So if there is some disease reported on CT angiogram, you have to do coronary. That's the practical my experience. If it is abnormal, if it is normal, you forget about coronary. If it is abnormal, if it is a moderate disease in LAD, then you have to subject them for coronary angiogram because the severity is not accurate. CT angiogram is not accurate in reporting severity. Again, the second problem of CT angiogram.
is the amount of dye contrast which we inject. In CT angiogram, you inject nearly minimum of 80 ml of contrast. In our conventional angiography, if it is uncomplicated, we finish our conventional angiography in 15 to 20 ml. Okay, so a person with a creatinine of 1.3, 1.4. Okay, although it looks CT angiogram non-invasive, attractive, I will be reluctant to send him for a CT angiogram with 80 ml of contrast. Okay, a conventional angiogram is going to give me a more reliable answer, especially if the pre-test likelihood is high. Patient is diabetic, 56, 60 years, and you have to know whether he has to undergo whether he had a coronary artery disease. You have to know a high risk double. Then the one industry I will prefer. CT angiogram, other value, suppose a patient of severe aortic stenosis. 50-year-old patient who is now to undergo aortic valve replacement, open heart surgery. A patient who has to undergo open heart surgery. Now, suppose he has a coronary artery disease, then naturally his bypass can be done at the same time, right? If he has to, he is definitely going to undergo open heart surgery for some reason. A 50-year-old man with aortic stenosis, 50-year-old man with calcific mitral stenosis, so whatever the condition. Now you want to know whether he has coronary, because you should be sure. You don't want to undergo again subject him to CABG later, second open heart surgery. So if he has a lesion 60-70%, why bypass? You may bypass him. At that time you can, if he is asymptomatic, his ECG doesn't show ischemic heart disease, then you can subject him for CT angiogram rather than coronary angiogram. Okay, just to know that coronaries are normal. If you have a suspicion that his coronaries are going to be abnormal, then subject to invasive coronary. Okay, so this is more to rule out the coronary artery disease, CT angiogram, than to confirm the coronary artery disease. That's the thing.
So huge intraluminal block for CT angiogram.
That's what I'm saying. The severity, not very less. For presence, it can take. If there is no significant calcification. Presence of calcification, presence of stent, all decreases sensitivity.
Actually, the 5 mm cuts are won't be able to pick out the intraluminal blocks.
If there is calcification, no, because there are artificals. The calcium throws a shadow. Okay, what we call it shows a reflective shadow, and that encroaches on the lumen, so you are not able to dye. If there is heavy calcium, so in heavily calcified, you cannot do CT. So got it. So these are the value of a particular test. Coronary angiography, everyone knows but it's a luminography. It doesn't tell you about the plaque characteristics. Coronary angiography, it just tells you degree of stenosis. The second thing, the disadvantage of coronary angiography is if the artery is uniformly narrow, then you won't tell degree of stenosis. Because when you say 70% stenosis, you compare it normal. But if it is uniformly, so if there is a diffusely diseased vessel, then you don't know whether it is 60% or 70%, because it diffusely narrow. So it's a luminogram. It just tells you about the lumen. It doesn't tell you about the plaque. Now, but this is the gold standard coronary angiography for ischemic heart disease. This is a gold standard, 100% sensitivity, 100% specific for this thing. But it is invasive, and we still have a sort of a phobia of subjective patient for coronary angiography. I think we should stop here for lunch. Okay. Any doubt?
Sir, have you opted for CT angio after going for coronary angiogram? Opted for CT angio after coronary angiogram?
If the anomaly, coronary anomaly is there.
Only that scenario?
Yes. Coronary, I have done many times. If it is anomalous, and if it goes between aorta and coronary, these are the patients who are prone for sudden cardiac death.
Okay, so you know circumflex is arising from right coronary artery on the major coronary angiogram. CT problem, because in CT angiogram you have injected 80 ml of contrast. You are able to see coronaries, you are able to see aorta, you are able to see pulmonary at the same time, and it's prone for sudden cardiac death. So here these patients need treatment, although there is no intraluminal lesion in that coronary artery. There is no stenosis. Got it? So in anomalous coronary arteries, to know their course, sometimes LAD, if it goes between aorta and pulmonary artery, these patients, so what happens, many times these patients complain of angina. Stress test is positive. You have anomalous artery on angiogram, but there is no lesion. Okay, so you have anomalous coronary artery, stress test is positive, angina, anomalous coronary artery and coronary. You subject them to CT angiography. So if the force of the that coronary is between aorta and pulmonary artery. If the force is between aorta and pulmonary artery, then that needs to be bypassed. That artery needs to be bypassed. You may go for nuclear scan. After coronary scan, if coronary angio shows normal origin of coronary arteries, then CT has no. But patient has angina. Coronary angiogram is normal. Then if you want to know that whether that angina is ischemia related or not, you may do a nuclear scan to know whether during angina there is a perfusion defect. If there is ischemia, then you have to give anti-ischemic treatment. If there is no ischemia, don't give anti-ischemic. Got it? And usually also spastic is usually ST elevation. You have suddenly coronary going into spasm and you have transmural ischemia. Okay. It is not a stress test positive sort of a situation. Stress test positive means your demand supply is altered. Okay. Vasospasm comes at any time. Any time. Why LVB is a problem? You see the electrical activation, right button wrong. The initial activation is from left to right through the common button. Initial activation of the septum. Okay. And in right bundle branch block, what happens is the initial activation is normal. It is from left to right. Normal. In left bundle branch, because the left bundle activates septum. In left bundle branch block, the septum is not activated through the normal channels. So the initial forces, what is called as vector forces, are abnormal in LVB. The initial forces are normal in RBB. So the depolarization is normal, repolarization is normal in initial forces. That's what we see in ischemia infarct. The Q wave is what the initial forces. ST depression is a repolarization initial forces. Okay, so the initial forces are not altered in RBB. That's why RBB, only what happens is there are secondary STT changes in RBB. V1 to V3, you have T wave inversion in RBB. So don't look at V1 to V3 when reporting stress test. You have to look at V5, V6, one AVN is reporting stress test. Got that point? So V1 to V3, what you have a secondary STT changes. Secondary means what? Secondary to depolarization, repolarization. So you have always have T inversion in V1 to V3 in right bundle branch. You always have. That's a normal for RBB. ST depression, T inversion in V1 to V3. Okay, but T is always upright in RBBB, STT in V5, V6 in only RBB. So you report STT in V5, V6, not in V1. RBBB is open.
Patient comes with
Now certain things like the blood pressure. Obviously you have to treat it when see the cholesterol. Now the variation of cholesterol. See, cholesterol, total cholesterol, LDL cholesterol variation is only 5%. Variation with diet, variation with season, and variation with diurnal variation. Only 5%. Total LDL cholesterol. triglyceride variation, it is a tune of 15 to 25%. Got it? That means I am talking only of good laboratories. I won't talk about laboratory to laboratory variation. There is some change with season, there is some change with day to day, and there is some change with diet. Right? Now this change is only 5% with total cholesterol and LDL cholesterol. 5%. Okay, so 200 cholesterol may become 210, it can become 190. Right? But triglyceride, this change is 15 to 25%. So 200 triglyceride, 25% change can become 250. Okay, so that's the significance. So for triglyceride, now so what the recent you don't have to fasting for which if you are interested in cholesterol. If you are interested in triglyceride, you have to be fasting. Right? Paradox. कसं आहे मला ते नाव आठवतं. याज्ञिक sir when he okay, his name was Yuan. Yajnik is Yajnik. So both names are starting with Y.
Lean fat Indians. That's the concept.
Huh?
That's a lean fat Indian.
Lean fat. Then he published a paper with his photograph and his colleague's photograph. His colleague is tall, hefty, and Yajnik is small. Okay, but when visceral fat was measured, Yajnik had a more fat than this tall, hefty. So that's what he labeled as the Y-Y paradox. We both are starting with Y. See the fat difference. You can get it on net. Just feed Y-Y paradox. That's it. So the concept is Yajnik, Dr. Yajnik, what he wants to tell is visceral fat is important. Your lid and everything boils down to the visceral fat. So you try to reduce it and you can measure the visceral fat by MRI. Your routine report of alcoholic fatty disease, you get very routine report. When you send patient for ultrasound, you say that fatty, we tend to ignore. But Dr. Yajnik says that is important. That's the first stage of increasing visceral fat. And these patients are more from vascular events later. And you start to attempt to reduce this visceral fat. And your waist to hip ratio is an indirect measure of visceral fat. Waist to hip ratio is an indirect measure of visceral fat.
So suppose some
Lifestyle modification, I won't say that is, but because that's one of the theories. That's not done in the guideline. That's what his theory is working on. His research is basically on that.
lifestyle modification should be the concept.
Yeah.
What do you do about homocysteine? What do you do?
I measure homocysteine, but I'm not very aggressive. In young infarct, 30-year-old, he develops infarct. But I measure homocysteine in permeable, in young permeable. And in fact, 2-3 patients I have whose homocysteine was more than 6. They have recurrent episode. That one patient I remember, he first presented me with myocardial infarction. Okay. Then 1 year later, he went to Dr. Jagirdar with the mesenteric stem. Then 6 months later, he came to me with peripheral vascular occlusion. 6 months later, he had pulmonary embolism. And he had the very high, not measured, they have measured it as more than 60. They have not given a value. He has a very high homocysteine. So those cases, it is a thrombocysteine. Thrombocysteine, if you have a venous as well as arterial thrombosis, measure homocysteine. Strokes are more religious about measuring homocysteine. In stroke, neurologists are more religious. Cardiologist enthusiasm has gone down over last 15 years. 2000, in the year 2000, 2001, 2002, I was very aggressive. Now, because basically intervention has not reduced. In fact, one trial mentioned in New England Journal, they gave treatment and the stent got blocked. That's after aggressive reduction of homocysteine. So, vitamin E, aggressive treatment with vitamin E. That's what was given as a treatment for homocysteine, vitamin E. So That's what happened to there. So homocysteine you measure how aggressive you should be.
Dr. Anis Pawar, Dr. Tulisha, Dr. Puyafani,
I'm Dr. Avinash Pandure, physician in the section मुळे biodiversity सुद्धा. तो सोपी आहे आता diabetologist पुस्तक. Dr. Bhaskar Patel, Solar, diabetologist. Physician Solar.
physician internship working in Ashwini Hospital, Surat.
Prashant Lord, physician Solar.
Vishal Gore, physician, Surat.
Because this is especially in young ladies and around perimenopausal ladies. Because usually you have ladies have that TCE, T inversion in inferior leads. That's a very common normal finding in ladies. This is a deoxyglycan effect. That's because of estrogen, and this effect is aggravated during stress state. So we can falsely label it as a positive stress test. So unless you have a strong compulsion or indication or suspicion of coronary artery disease, this may misguide, this stress test may misguide. If you have a typical angina with multiple risk factors, okay, you may go ahead with this thing. Otherwise, you are going to have a false positive stress test. Now, this is basically all we are physicians, so this is the slide they are dealing with the referral to cardiologist. Basically, to whom the invasive testing is indicated. As you know, a patient with typical angina with a high post-test, high pre-test probability of stress test. The stress test with many physicians, I think, are doing stress tests here. So, to have a definitive positive stress test with a post probability also high, perhaps will need an invasive angiogram to study the anatomy and plan for treatment. Now, there are certain case studies about this diagnostic test which test is ideal. Now, not that perhaps opinions might differ on which test to do, but this could is a general consensus of the faculty that these are the tests which need to be undertaken. Now, this is one case, a 55-year-old man evaluated for chest pain of 4 months duration. It describes pain and sharp located in the left chest with no radiation processes associated symptoms. The pain occurs with walking 1 to 2 blocks and resolves with rest. Occasional pain improves with continued walking and occurs during evening hours. He has hypertension on amlodipine, and there is no family history of the cardiovascular disease. When do you consider family history of coronary artery disease as significant? Any idea? One is sudden cardiac death, yes. Any age? Any just father at 80 years old, he has ischemic heart disease, that becomes a risk factor? It's less than 55. Less than 55 years age, if there is a history of coronary artery disease in the family, that is a significant family history. Okay. So, first degree, and in the first degree, naturally it is in the first degree. So, this conferred a risk, it has to be less than 55 years of age and in the first degree. Right? Now, this patient continued, his afFRL, BP is normal, pulse rate is normal, respiratory rate is normal, BMI slightly high, no bruise, no murmurs, so virtually normal clinical examination. So what is the next diagnostic step is naturally ECG. As you will see here, ECG is slightly leftward axis, but nothing to suggest ischemia. Will you agree? So what would be your next diagnostic test? So this is just to recapitulate, this is a 55-year-old man, hypertensive. He had chest pain, which sometimes increases on exercise, sometimes while walk continues when he walks, the pain is relieved. That's sharp on the left side, no radiation.
Yes.
So that's the chest pain description. He is hypertensive, no other risk factor. Examination is totally normal. So that's the brief summary of this pain. So this patient has some typical features of chest pain, except atypical. The atypical feature, the pain is left-sided. You know the angina pain is a retrosternal. So this is the atypical, sharp pain. That's atypical. It is heaviness, tightness. That's a typical feature. So this is an atypical feature. The typical feature is increases on walking. That's a typical feature. And sometimes while continuously walking, the pain is relieved. This is a walk-through angina. So these two are, so he has some typical features, some atypical features. So he would fit in a pre-test probability of intermediate. He's not a typical angina. Okay, you can say he's a atypical angina. So he would fit in somewhere then we just see where would he fit in the pre-test probability Bayesian theorem. Okay. He would have a pre-test probability of nearly 60-65%. So, as per this thing, this is a high intermediate probability. So, he is the best person to undergo stress test. So that's the answer. So stress test is the answer to this patient. Nuclear perfusion for a walking man with a normal ECG, no resting ECG abnormalities, and it's obviously a high cost involved. Angiography, of course, we are not going to consider. Echocardiography is on antihypertensive. Examination, BP is high normal, heart rate is normal, BMI is high, CVP is normal. There is a soft murmur at base, and EC shows LVH with strain. So what do you feel is the best diagnostic test to perform? Is it adenosine, CT, myocardial, perfusion imaging, coronary angiogram, dobutamine stress, exercise stress? See, exercise stress test is out, she is not able to walk. Okay. Now we have three. Adenosine, adenosine increases bronchospasms. So we cannot do adenosine CT myocardial. Now the choice is between coronary angio versus dobutamine. My preference would have been coronary.
High risk.
Because it's a high period, she's already had an event. But their answer is dobutamine. That's their answer. But I know she's already had angio, she has recent onset dyspnea. Okay, but that's what it. The point probably they want to emphasize is that with resting ECG abnormalities, patient who is not able to walk, when the diagnosis is in doubt, you should go for a dobutamine stress. That's what the message probably they want to convey, and we'll follow that protocol. So this is a patient who had resting ECG abnormalities, but effort tolerance is low. Because of COPD, her adenosine testing cannot be done. So the only choice that remains is a dobutamine stress testing, short of angio. But angio is a good investigation, definitely, and maybe in practice we would go ahead. A 66-year-old woman evaluated for 3-week history of worsening dyspnea on exercise. Medical history is significant for diabetes and hypertension. And she is on antihypertensive, BP is normal, pulse rate is normal, respiratory is normal, BMI is on higher side, and resting are normal. So EC shows left atrial. Now again, a typical patient with a resting ECG abnormality, stress test is out of question. Stress test is out of question. Coronary artery calcium scoring, I told you, is not going to tell us. It might show us calcium everywhere, but that will not tell us whether she has significant lesions. Now again the choice is between angio and nuclear perfusion imaging. So the non-invasive choice would be a vasodilator, nuclear perfusion imaging. Okay. A 62-year-old man.
Here they say that vascular nuclear perfusion imaging indication is for intermediate group of patients. When the pre-test probability for CAD is intermediate, then we should go for this. As per the history, if we try
This
to,
is a high probability.
this is a high
It's
probability.
ideally we should. These last two cases, I have my own suspicion
If
because.
we go with the pre-test probability, then
Yes,
there
if we,
is some
definitely,
risk.
I think this is a, but for, I think probably they don't want to, the thing is, basic principle of this course is they don't want to convey a message and what do you say, propagate a message of unnecessary coronary angiograms.
But as
That
per-
is the message probably they want to do. So before coronary angiogram, a non-invasive test, a diagnostic test. So that is the message which I am getting from this. This is what they want to convey. Ideally, this patient should undergo angiogram. The previous patient also who has already undergone angioplasty and recent onset dyspnea, the first thing which we will, if there is no other respiratory problem, we will think of a coronary angiogram. But probably the message there and probably some representative examples should have been readjusted. They should have kept it in the intermediate probability and then probably would have worked it well. But this is, we'll go with that. A 62-year-old man evaluated during a routine visit, he is asymptomatic and walks 1 mile most of the week. Medical history is significant for aortic stenosis. He is diabetic, hypertensive, hyperlipidemic and on suitable medications. He has blood pressure which is normal, pulse rate is normal, respiratory rate is normal, BMI is high, and he has a murmur of aortic stenosis. Laboratory studies, the cholesterol is normal, ECG is normal, there is a mild aortic stenosis, and EF is normal. Now, what is the appropriate management? Should he undergo echocardiogram? Should he undergo, already there are echocardiography data they have given with a gradient of 13. Now the thing is what they want to know is this is a patient, whether he should be investigated to rule out associated coronary artery disease. In aortic stenosis, 50% of patients of aortic stenosis, they have coronary artery disease. Okay, that's the standard statistics. 50% of aortic stenosis, severe aortic stenosis, they have coronary artery disease. Now, you know what is life expectancy in aortic stenosis? That is 532. That is patients who have exertional angina history. Their approximate life expectancy is 5 years. Okay, those who have syncope, their life expectancy is 3 years. And those who are gross dyspnea, class 3 dyspnea or in heart failure, it is less than 2 years. That's it. So this patient fits in none of these. He is walking for more than 1 mile. He has not had any other symptoms attributable to aortic stenosis. What we gather is this aortic stenosis has been diagnosed purely as an incidental finding when he came for examination. So his ECG is normal. The Doppler shows a gradient of only 13, which is just on the borderline, even not a mild aortic stenosis. So he has a clinical murmur disease. So the thing is, sometimes aortic stenosis can give rise to false positive stress test. So ECG is out of question. Echocardiography also already is done. There are no symptoms. So it does not need additional testing at the moment because he is asymptomatic, documented mild aortic stenosis. So what are we testing for? That's the message. So it does not need any additional testing. We leave it at this. This is probably this. So what are the take-home messages? Is CVD is number one cause of death and disability in the world as well as in India. We need, definitely, I think you will agree that some knowledge of statistics, biostatistics is essential. I hope you got that message, and little you will be wiser today when you read the next paper. Then CVD is influenced by the risk factors we know, and because of the alarming nature of the CAD, we have to be on guard and we have to screen the patients for presence of coronary disease, especially in the high risk subgroups with appropriate test, knowing what is the pre-test probability. Now the next module, the learning objectives are this. We are going to again go to the other risk determinants of CVD, tobacco, physical activity, inactivity, diet, alcohol, air pollution, etc. I think this we will cover in the next session. Thank you. Notifications, any, what you are, about today's session, I want a frank opinion about everything, about the content, about the method of teaching, and about food, what are any facts, because this is, I am also new to this, and I would like to improve with your suggestions. So anything you want to suggest, any area which needs improvement? Yes? One still I think I have loaded 2.5 hours. Yeah. They said minimum 4 hours. And it is not. It was fast. Biostat. That's the epidemiology.
Your exam was clear, but you have been
Okay, fine. I will go on that next time. Anything? I hope you come next time.
It's a wonderful course. It's really a wonderful course. The books are very concise and each and every line is not to be missed. हर का है, topics are का एक line में है, so what? And slides are good and you are given examples very nicely. They were good explanatory. Reading the book could not have helped us until unless you have given us the examples, practical examples.
Listen what Dr. Parais has to say.
Yeah, I will try to make that more because this is a what 52 centers are following this, so we should not be exception. So we will try to stick to the line, but we have our own disagreements and reservations that I will express you also where you feel like. But this is not a final God's word. We have to learn and these concepts keep evolving, changing. But by and large, we will stick to their mode of whatever their concepts they are put forth. We will stick to that. Any other? I have the maximum attended program. Most are around 18 participated, around 18 most of the centers. We have 24 or 25. It is all credit to you. So let's try to, next time, what date should it be? Maybe after Ganpati?
Yes.
20